So, we all know that its normal range is somewhere gets given as a -2. Normally, the standard is -2 to +2. In ICU, they will call, because of that lot of changes in the ICU patient, that is -3 to +3 is the normal range. If it is base excess is in the positive, it is higher, it is a metabolic alkalosis, acid is removed from the body. The base excess is in the negative, which means that acid is added to the body, build up in the body, lactic acidosis, ketoacidosis, phosphoric acid, renal failure, and hypochloremic, dysentery. All these conditions, what will happen? The base excess will be more negative. It more positive means it is a metabolic alkalosis, more negative means it is a metabolic acidosis. So, this has some problem with that. There is some formulas are there to calculate the base excess. It is called, there is a Vance equation. This equation, there is it included the hemoglobin, okay, bicarbonate and everything, pH, everything to calculate the base excess. So, this is the most common formula used in the ABG machine to calculate my base excess. So, in this various ABG machines, if example, I calculated one base excess in same patient's blood from the different ABG machines, the ABG machines can give the different values of base excess for the two reasons. One is that some of the ABG machines use the hemoglobin concentration as a fixed 15. Some of the ABG machines will measure the hemoglobin level, calculate the hemoglobin level and include the equation. Some of the ABG machines will take it as a fixed 15, some will be a fixed, some will take as a 15 always constant. Some ABG machine will use a constant hemoglobin level as a 12. So, that is the reason the base excess value will can be a different in the if you use a different ABG machines. Okay. So, something is, there is some problem is that, okay. What they did, that base excess is, they took a blood sample from the patient's blood, okay. In a vitro, for example, they check the pH of example 7.1, they measured a buffer base excess of, they added pH. What they did? They added bicarbonate to that to bring the pH of 7.4. This is my normal pH. Then they measured how much of bicarbonate acid is needed to bring the pH from 7.1 to 7.4. That is the patient's base excess. If example, they needed 10 bicarbonate to bring the pH to 7.1 to 7.4, they call it as a base excess of -10. So, what they did is in vivo they measured a base excess. Something is called standard base excess. Why it is called a standard base excess? Because the blood, that the base excess is give idea about the acid base status of the blood, but not its acid base status of extracellular fluid. Okay. The extracellular fluid, not only the blood, the 2/3 of the extracellular fluid will be a interstitial fluid. Okay. To take it as a standard base excess, I need a whole body acid base status, not the whole blood acid base status. To overcome this limitation, they introduced something like a standard base excess. Okay. They corrected, for example, the hemoglobin value is 15 in the blood fluid, extracellular fluid does not have the hemoglobin. It is a 2/3 of the fluid is extracellular fluid, interstitial fluid. To overcome that, they take it as a average hemoglobin concentration as a 1/3 of blood hemoglobin. So, it is a average of all over the extracellular fluid and the intravascular fluid. So, the base excess is calculated, the hemoglobin concentration 30 to 50. For example, 15 is my normal range of hemoglobin in the body. They take it as a 5 in the as a hemoglobin value to correct the base excess. So, it gives the whole body base excess value. Okay. This attempt to eliminate the error introduced by the incorrect assumption of blood buffering the blood is the same as the buffering of the whole ECF. So, the standard bicarbonate will give idea about the whole body buffer. Standard base excess, the normal base excess will give idea about the whole blood buffer. Okay. So, I want to know whole body buffer. So, always use a standard base excess is the best method to assess the metabolic acid base disorder. Okay. So far we discussed about that there are 3 ways to assess the metabolic acid base disturbances, which is proposed by the Dutch group. It is called the Copenhagen approach. Okay. They said the first method is a standard bicarbonate. Okay. The standard bicarbonate is a ABG bicarbonate, it's a calculated from the pH and PCO2. It is called actual bicarbonate. This actual bicarbonate is corrected with the normal PCO2 level. So, it is called standard bicarbonate. What is the limitation of standard bicarbonate? It is a respiratory independent. But what is the problem with it? Is non-carbonate bicarbonate buffer systems are not included in it. So, it has one limitation. To overcome that, they propose something called buffer base. The buffer base is a total carbonic and non-carbonic buffer base concentration, buffer anion concentration. This buffer base concentrations are respiratory independent, metabolic dependent. It will decrease or increase only in the metabolic acid base disorder. Okay, it is a good one to assess the metabolic acid base disturbances. But what is the problem with that? It cannot exactly give idea about how much soda bicarb I have to give the patients to correct the metabolic acid. Otherwise, how much acid I have to give the patient to correct my metabolic alkalosis. To overcome that, the Dutch group proposed something called base excess. So, the base excess is what is the difference between the actual buffer base and the normal buffer base. It is called base excess. So, the base excess, that is something is called base excess, give idea about the whole body buffers. Base excess is not a whole body buffer, it is a whole blood buffer. What we need actually whole body buffer. To correct that, we need to something like a standard base excess. They took an average hemoglobin concentration in the standard bicarbonate, standard base excess. The base excess, they included the actual hemoglobin. So, there is to calculate to the standard base excess, we need a few formulas there. There is one of the simple one is the bicarbonate, its actual bicarbonate. It is a patient's actual bicarbonate. This is my patient's normal value of bicarbonate. The 16.2 is a non-bicarbonate buffer power. It is a constant one. This is a patient's pH. If you put all these things, we can calculate the standard base excess. Standard base excess is respiratory independent. It can quantify, it is a respiratory independent. Second thing, it is a whole body metabolic disturbances. The third one is you can exactly quantify how much acid or alkali I have to give to correct my metabolic acid base disturbance. These are the advantages of them. So far we discussed about why the base excess is proposed by the Dutch group. Why the Dutch group, how they are criticizing. They say in the physiological approach, they said PCO2, it's actually representing the respiratory disturbances. The bicarbonate is not representing the metabolic disturbances. The bicarbonate affected by the respiratory disorders also. Dutch group said that to assess the metabolic disturbances, we need one of the independent marker to assess the metabolic disturbances. They proposed the three ways. The first, they introduced a standard bicarbonate. Later, they introduced buffer base. The last one is they introduce a base excess. From the base excess, we can assess the acid base disorder. So, some of the measurement errors will come. I already told that the intermachine variability. Each machine will use the different formulas to calculate the standard base excess. So, the maximum difference is 3.7 millimole per liter. It is clinically significant. I already told a -2 to +2 is a normal base excess. If anything beyond that range, it is abnormal. This intermachine variability itself 3.7 millimole per liter, which means that it is clinically significant. Preferably use a single machine when you are comparing the previous base excess to make any decision to change in any of your treatment. Okay, one. Second thing, there is some variation between the measurement within the same machine, but it is very insignificant. See, it is 0.24 to 0.48. I think we can ignore it. Some of the arterial and venous samples also have some limitations. One point, the main is the intermachine variability. It can mislead your interpretation of base excess. Okay, what is the advantages of? I already told. The base excess is a purely respiratory metabolic dependent. It's only change when you have the metabolic acid base disorder. Second, it estimate the amount of metabolic acid, give exact how much acid I have to give, how much alkali I have to give to correct the acid base disturbances. One. So, standard base excess with the important tool, it determines the severity of illness in the acute care setting. Okay. So, it give idea about how sick my patient is there. If example, you receive one patient from the ER to ICU. If you found the standard base excess, one patient have a -5, one patient have a -16. The -16 that have this patient is a very sick. It's like lactate. Lactate is very high. Lactate is a single way. For example, the patient comes to, one patient comes to with a cardiogenic shock with a lactate of 16. Other patient comes to a cardiogenic shock with a lactate of -5. It means the 16 have the higher, the illness is very severe in those patients. It's like standard base excess also. Higher the negative, the patient is, the severity of illness is very high. One. The second thing, it's not only acute illness, non-specific, it also in the specific situation. To detecting the hypovolemic shock, it is stratifying the patients in hemorrhagic shock. The both hypovolemic shock and hemorrhagic shock, also we can identify the shock is severe, severity of the shock by the looking the standard base excess. It is also one of the good predictor of massive transfusions. If the base excess is very high in the trauma patients, very more negative, the patient may need massive transfusion. One. Okay. But in the patients with trauma, it is also predictor of risk of death. How severe, example, it is a severe, it giving idea about how severe the trauma. It also give idea about how much transfusion my patient need. It also give idea about mortality predictor. So, compared to that, it is a good mortality predictor compared to the other signs, example our heart rate, BP, shock index. Compared to these parameters, the standard base excess is a good predictor of death in a patients with trauma. Okay, these are the advantages of my base excess. Okay, so limitations. So it is estimate the amount of acid base, metabolic acid base drug, but it won't provide any information about the underlying mechanism. Okay, the base excess may decrease. For example, it may be a more negative, it may be a hypochloremic acidosis, or it may be a anion gap metabolic DKA, or it may be alcohol ethanol poisoning, or it may be a lactic acidosis. All these conditions will decrease the base excess. So, it won't provide any information about the underlying mechanism. One, the same thing, it is a composite marker. It gives the overall picture of my acid base status, metabolic acid base status. For example, my patient having DKA comes with vomiting. The DKA, what will happen? The accumulation of acid may decrease my base excess. It will cause maybe it's -10. If excessive vomiting, what will happen? Loss of acids, it increase my alkali level. Okay, sometimes it may be that it's vomiting causing metabolic alkalosis, increasing my more positive base excess. My DKA, it is more negative base excess. It may be neutralized with each other. The patients might come to your ICU with severe DKA with normal standard base excess. Okay. So, the two pathological process with opposite sign or present would be missed if the standard base excess was assessed on its own. So, the abnormal standard base excess always is a reliable marker of active metabolic issue, but the normal base excess, it cannot exclude the acid base disturbance. I already told, the patient, DKA patient comes with severe vomiting, the patient might have the normal standard base excess, but doesn't mean that the patient doesn't have acid base disorders. Okay, the abnormal standard base excess is a good marker to assess the metabolic disturbances, but the normal base excess won't rule out the acid base disturbances. It's very important. Okay, so standard base excess cannot be considered as a standalone parameter. You cannot make a decisions only based on the standard base excess. So, because of these limitations, they did some of the modifications or they interpret with other parameters to assess the acid base disorder by using the standard base excess. How can you, the next going to be how you can use the standard base excess to assess the acid base disorder. The first thing, okay, there is a 3 steps are there to assess the acid base disorder by using the standard base excess. The first step is that to evaluate the standard base excess in relation to the pH and PCO2. Okay. In the physiological approach, how will you approach? The first step is use the bicarbonate in relation to the pH. Physiological order, you will check a pH, PCO2 and the bicarbonate. In the Copenhagen approach, in the base excess approach, we won't use the bicarbonate because I already told bicarbonate is a respiratory dependent. Here we will use the base excess. So, we decide to assess the acid base is the first step. 3 parameters we will see: pH, PCO2 and base excess. First, we know that reference normal values, the pH is 7.4 is normal, PCO2 is 40, the standard base excess -2 to +2 is the normal one. It is a normal range. Okay. Something called base X deficit. It's very confusing picture. Nothing. Base deficit is a negative value of my base excess. Okay. For example, the base excess, call it the -10 equal to the base deficit is 10. It's equal. The base deficit is a negative value of, if it 10, if example my base excess is -10, my deficit is a negative value of -10, it will be the base deficit will be negative value of base excess. Okay. So, if example my patient, first step is I checking my pH, it is less than 7.35, okay, it is acidosis. Next I checking with my standard base excess, it is less than, it is -2, it is example -4, which means that it is a metabolic acidosis. Or if I checking my PCO2 is more than 45, it may be a respiratory acidosis. First I have to check a pH, PCO2 and the standard bicarbonate. It is my first step to assess the acid base disorder by using the base excess method. I already told, to use the base excess they need some modifications. Okay. Something called secondary. Second step is to look for the secondary response. If example, if it is acute respiratory acidosis, we already discussed that. In acute respiratory acidosis, the renal compensation won't occur. That is, you won't see any changes in a standard bicarbonate, because the standard bicarbonate is not respiratory dependent. So, acute respiratory acidosis and respiratory alkalosis, you won't see any changes in a standard bicarbonate. There is no secondary response. If it is a chronic respiratory acidosis, what my body will do? To compensate that, the chronic respiratory acidosis, my renal, my kidney itself will going to retain the bicarbonate. So, it going to increase my bicarbonate level. So, it going to increase my standard base excess. In chronic respiratory acidosis, my standard bicarbonate base excess will increase. There is some formulas are there to calculate that. So, it is a 0.4 into PCO2 minus 40 is you can give the change in your standard base excess 1. Chronic alkalosis also the same formula you can use it to see the secondary response in the standard base excess. To the metabolic acidosis, what will happen? The pH will decrease. What will happen? The standard base excess also will more negative. It is decreased. My PCO2 to response to secondary response, my PCO2 will decrease. To calculate the PCO2 change equal to my standard base excess. In the metabolic alkalosis, what is the response you will see? The pH will increase, standard base excess will increase. To secondary response, my PCO2 also will increase. There is a formula to calculate the expected PCO2 change when in the metabolic acidosis by using a standard base excess. These formulas have to memorize. Okay, the acute respiratory alkalosis, acute respiratory disease, you won't see any change in the standard base excess because standard base excess is not respiratory dependent. In the chronic respiratory acidosis, the CO2 retention directly won't increase the standard base excess or decrease. It indirectly it going to activate the renal second compensatory system. It going to retain the bicarbonate. It going to retain the alkali. So, it increases our standard base excess. So, the third step is that there is a mixed acid base disorders. Maybe the base excess will give idea about it is a metabolic acidosis or alkalosis. But how do I know this metabolic acidosis is a anion gap high anion gap metabolism or it may be normal anion gap metabolic acidosis? To assess the complex metabolic disorder or mixed metabolic disorder, there is you will go for the third step. In the third step, there is a two ways we can differentiate the high anion gap and normal anion gap metabolic acidosis by using the base excess approach. One is that based on that Stewart's principle, they slightly modified in this way. They said the base excess, it is a lab values depends upon 4 parameters: base excess of free water, base excess of chloride, base excess of albumin and base excess of unmeasured anions. So, how can you calculate the standard base excess due to free water? It's simple. It's a 0.3 into my patient sodium minus 140. It gives value about this value. From the chloride, I can calculate the 104 minus chloride of patient's chloride into 140 divided by my sodium. It gives the base excess of chloride. From the albumin, I can use this formula. It gives the albumin. Okay. Okay, I calculated from these values, from my base excess is around 5. So, it's example 5 from this value. I measured from the ABG, it is also 5. The difference between these two is 0. Okay. If it is other hand, my measure from ABG from the base excess was 10. Okay. From here, what I calculated from here is only 5. There is a 5 base excess is extra is there, which is contributed by the unmeasured anions. So, it is maybe the metabolic acidosis may be related to high anion gap metabolic acidosis. From that, we can differentiate between the high anion gap or normal anion gap metabolic acidosis. So, it is simple, standard base excess, okay, it is unmeasured minus my standard base excess of free water and chloride or albumin. Okay. For example, my standard base excess is something is 10, all these values are only 5, which means that the 5 unmeasured anions are there. It may be a DKA, it may be a lactic acidosis, or it may be a ethanol poisoning, so whatever that. So, it is a this metabolic acidosis may be a high anion gap metabolic acidosis. This is the one way to differentiate the high anion gap, normal anion gap acidosis by through the base excess approach. What is the other way? Simple, the same anion gap method is included here. Okay. We know all how you calculate the anion gap. It is a sodium minus chloride plus bicarbonate. The normal value is 8 to 12. If it is more than that, which may be the protein or phosphate or sulfate, organic anions are occluded in the body. So, there is two ways we can, first step is you have to look at pH, PCO2 and the standard base excess. Second base is look for the secondary response. We have some formulas to see the secondary response. If the secondary response, example, this much of base excess, my PCO2 should be 40, but my PCO2 is 50, means the patient having metabolic respiratory acidosis also. Okay. The secondary response is expected secondary response and actual patient's values are not matching. There is something is called, if there is a second one more acid base disorder is there associated with the primary acid base disorder. We will take it as a one case, the patients with renal failure with ileal orthotopic neobladder, it is a ileal conduit for the some CA bladder. Okay, he already on chemotherapy of cisplatin something. Okay. So, we checking the values here. First, we see how will you approach the acid base disorder by the base excess method. First, we will see the what is the pH value. It is a 6.91. Okay, it is a acidosis there. Next, I will checking my base excess. What is the base excess is minus 28, which means that it is a severe metabolic acidosis is that. Okay. Next, I am checking my PCO2 level. It is also secondary compensation is there. It may, I don't know, it's adequate or not, I have to check it. So, 3 parameters we saw, seeing it is a severe metabolic acidosis is that one. What is the second step? I have to see the secondary response of the hyperventilation to the metabolic acidosis adequate or not. If it is adequate, means it is only metabolic acidosis. If it is more than that, which means that the PCO2 level is lesser than the expected, it means that respiratory alkalosis component also there. It is more than the expected, it may be associated metabolic acidosis with the respiratory acidosis. This is the second step. The third step is that I have to look for that is there are any associated high anion gap metabolic acidosis, or it is a normal anion gap acidosis, or it is a both. Okay. So, I have to check that. Okay. So, first step is that I already told the pH is 6.9, the PC standard base excess is minus 28. So, it is a metabolic acidosis. Second step is I have to calculate my secondary response is adequate, appropriate or not. So, what is the formula for the metabolic acidosis? It is a PCO2 is the my delta standard base excess. So, standard base excess is minus 28. Okay. What is the my PCO2? Change should be, so it is a minus, it is a normal PCO2 level, minus I am saying this is my actual PCO2. So, that is my change in the PCO2 level. So, minus 28, what will be the ideal PCO2 here? It is a 12. What is the PCO2 here? 6.2. So, there is some respiratory alkalosis also. So, there is metabolic acidosis plus respiratory alkalosis also there. Okay, one. So, should not confuse that. Is the metabolic acidosis, you will see the PCO2 change is the delta standard base excess. The standard base excess is minus 28. Change in the PCO2 should be minus 28. So, I have to decrease from the my normal value minus 40 minus 28. So, ideally my PCO2 should be 12, but it is lesser than that. So, it is a metabolic acidosis with plus respiratory alkalosis. Third step is I have to differentiate, is there any metabolic high anion gap metabolic acidosis or normal anion gap metabolic acidosis is there. So, the two ways, one by the portioning of the standard base excess by the free water standard base excess, chloride standard base excess, albumin base excess, then I have to calculate. Otherwise, it is just simple is a looking for the correct anion gap. So, easiest way is going for anion gap. So, we using in this case as anion gap method. So, in this formula is the corrected anion gap is around 90, normally it should be 10 to 12. So, it is more than that. So, it is a high anion gap metabolic acidosis also there. The formula is that there is a high anion gap metabolic acidosis and respiratory alkalosis there. Okay. What is the normal anion gap acidosis here? Normal anion gap acidosis also there. How do I know that? Okay. For example, my anion gap is increased how much? Normal is 12. How much here? It is 19. So, how much is increased? So, 7. So, how much bicarbonate has to decrease? If it is 7 acids are added, how much bicarbonate has to decrease? 7 only, right? So, if example, it is 24 is normal, what should be the bicarbonate here? It should be 17. Okay. What is the bicarbonate here actually? It is a 1.4, which means that it is more than that. Ideally, it should be 17 if it is only high anion gap metabolic acidosis. Here it is 1.4 means some other normal anion gap acidosis also added to that. Okay. So, it is a metabolic acidosis, it is a respiratory alkalosis, it is a high anion gap metabolic acidosis also there and normal anion gap metabolic acidosis also there. So, it is high normal anion gap metabolic acidosis with the respiratory alkalosis. This is the way you can use the base excess approach to assess the acid base disorder. There is one more case. It is a 36 years male with a type 1 diabetes coming with vomiting and the fever. Okay. So, the pH is 7.53, my PCO2 is 32, then my standard bicarbonate is 27. If you see first 3 parameters, the step 1. Okay. Step 2 is I have to look for the standard bicarbonate, standard base excess is 4.7. So, I have to be this 1, 2. There is a pH, PCO2 and standard base excess, we can step 1. The second step is I have to look for the secondary response in the PCO2 level, it is a step 2. Third one is I have to look for the anion gap or portioning of the standard base excess is a step 3. Okay. So, first we start with here, what is the pH here? It is higher than the reference range, it should be, it is more than the 7.4. So, it is a alkalosis there. My standard base excess is in the positive. So, what is that? Which means the patient having a metabolic alkalosis. The second step is I have to look for the my PCO2 level is appropriate to the metabolic alkalosis. Okay. So, to assess the secondary response, we already discussed the standard bicarbonate in the 0.6 will give idea about the PCO2 change. Okay. It is a 2.82. If I put standard base excess is 4.7 into 0.6, it is a 2.82. Ideally, what would be my PCO2 level? It is a 42, but it is a lesser than that. So, the metabolic alkalosis associated with respiratory alkalosis there. Next, I have to check my corrected anion gap. What is the corrected anion gap from here? If you put, for example, 144 minus 93 minus my standard bicarbonate is 27. So, it comes under, so it is 10, so it is around 120. So, 144 minus 120 is 24. If I correct my corrector to the albumin, how much will come? Each is a normal by albumin is 40. Each 10 milligram per liter drop in albumin, you will add the 2.5 have to add. So, it is less than, there are 10 gram difference between the actual albumin and the patient's albumin. So, I have to add with the 2.5. So, corrected high anion gap is 26.5. Okay. So, it is associated with the high anion gap metabolic acidosis there. Okay. So, the patient having high anion gap metabolic acidosis and metabolic alkalosis and respiratory alkalosis to us. So, metabolic alkalosis, high anion gap metabolic acidosis with respiratory alkalosis. Always whenever interpreting the acid base disorder, always you have to correlate with the clinical picture and clinical history. Okay, it's very important because this all there is secondary response formula both in the physiological approach or in the standard base excess approach. It is not well studied or well calculated. So, it may give confusing picture, maybe the patient having additional metabolic acid base disturbance. You take this patient actually. Okay. So, what is that? Is metabolic alkalosis with high anion metabolic acidosis with the respiratory alkalosis. You see, what is C here? If the patient comes with a type 1 respiratory, type 1 diabetic mellitus, this patient might have high chances to have high anion gap metabolic acidosis. Second, this patient having a vomiting. So, this patient have a metabolic alkalosis. Second thing, the patient have some amount of fever and sepsis component also, that may be caused slight tachypneic or to that acute lung injury, respiratory alkalosis. So, this history and the clinical picture is explaining the all our acid base disorder, high anion gap acidosis with metabolic alkalosis with respiratory alkalosis. Okay. So, always whenever we are interpreting the ABG report, you have to compare your clinical picture and the history, then only we can identify the correct acid base disturbances. So, thank you that the base excess approach, it is you can use it in our bedside with appropriate clinical history and appropriate interpretation. So, the base excess approach is actually, it is as simple as the physiological approach. Most of our bedside will use a physiological approach. The base excess approach also we can try at the bedside if you follow all these 3 steps, step 1, step 2 and step 3. So, in the next class we will see about another important topic in acid base disorder is Stewart approach. Thank you.